Welcome to the Doctors on Social Media podcast. Welcome to SoMeDocs. I'm the founder of this venture, Dr. Donna Coriel, a curious internist turned digital entrepreneur. I run this beautiful community and encourage you all to subscribe, engage, and join us at doctorsonsocialmedia.com. The following is a conversation we had with a professional in healthcare, now available to both watch in video or listen to through audio podcast. We hope it entertains, inspires, and ignites conversation. Don't forget to check out our other unique resources on our website, and of course, share this with your friends. Hi, everyone. So this is yet another conversation. I'm really excited to have Dr. Jay Joshi next to me virtually. Jay, I'm going to have you introduce yourself, and then we're going to get right into conversation.
Sure. So my name is Dr. Joshi. I'm a primary care physician. I practice regenerative medicine in Northwest Indiana. I'm also the founder of Daily Remedy, which is a health media outlet. And I have a very interesting backstory that involves the DEA. So like without uh, kind of diddle-daddling, let me cut to the chase. So I think that's very important for the audience. In 2017, I started my first primary care practice. So I was practicing in Northwest Indiana, and I finally saved up enough to start my own practice. We were trying to be at that time, like many clinics were, an MA-based clinic, so Medicare Advantage, and really focus on quality. And I grew the clinic pretty decently. And what had happened was a patient was writing scripts under my name. And uh, what I found out and I reported her to the Munster police. And what interestingly would happen is that then triggered a DEA investigation into me, where they then sent undercover agent posing as a patient with leg pain to my practice. And I remember vividly now. He was a truck driver who moved from Florida to Indiana, didn't have insurance just yet, but wanted to transfer his care. And he was taking, apparently, that's the story he was telling me, Vicodin 10 500 3 times a day. I told him I'm not comfortable giving him that as a starting dose. And so I started him at Norco 7.5 325. We reviewed his inspect, which is a prescription database, um, did all the things, physical exam, everything. And he came 4 times, and that was, according to the DEA, sufficient enough to proceed with the raid on my clinic. And the raid took place on November 21st, 2017. And what was very interesting about this is that they came in with like AK-47s, bulletproof vests, and my patients were all there. We were like a normal clinic, and they basically siloed all the patients in one area, siloed my staff and myself in another one. They took my phones, they started going through my phone. They put me in a holding cell, and I didn't know what was going on. I just did whatever they said. And then after like 3 hours, they gave me some documents and said, if you want to go, sign these documents. And well, I signed those documents, and I didn't know any better. But that basically just took away my DEA prescribing rights. And next thing I know, about 3, 4 months later, I was indicted. And the indictment was they basically had the total number of controlled substances, which they knew wasn't because of my practice, and they had the undercover agent visits. So essentially, what they did is they were able to create this portrayal like I was a high prescriber, right? By saying this is the X number of prescriptions written, and the undercover agent came in, and what they basically determined was that the quality of my physical exam was not sufficient to justify the continuation of prescription opioids. So it wasn't that there was a lack of a physical exam, it was that the quality of the physical exam wasn't sufficient. As apparently the DEA says that they don't regulate the practice of medicine, but when it comes to legal cases, they sure as hell know how to interpret the law in their favor. So this was before Ruan v. United States, which is a Supreme Court case in 2022, which I was involved in. So I couldn't say that I was acting in the best interest of a patient. So I pled guilty. And like many physicians involved in opiate epidemic, the prosecutors wanted to make an example. And interestingly enough, the prosecutor in this case, he's now a judge, Thomas Kirsch. Uh, he's basically an appellate court judge, so one step below the Supreme Court. what was very interesting is when I was reviewing his application to the Senate Judiciary Committee to become a judge, he had my case listed as one of the cases to discuss. And I thought that was very interesting. And so Thomas Kirsch was a very ambitious prosecutor, like many AGs and prosecutors are when they go after physicians, because that's like the white whale. If you can get a physician conviction or a physician civil matter under your belt, then you out that, and that's a boost to your resume. And so he really wanted to make an example. So he sent me to prison. And I ended up serving 11 months. So they gave me a 15-month sentence based on the number of prescription opioids that were prescribed. They have this weird system where they uh, they consider the prescription in terms of the actual pills itself. So when they sentence you as if you were engaging in a drug transaction. So they don't consider the fact that you wrote four prescriptions for four visits. No, it's like Norco 7.5, 325 twice a day. So that's 60 multiplied by four, 240. Actually, it was less than 240 because I actually started tapering him the fourth visit. So I was tapering him down, but they didn't really take that into consideration because, why not? Um, and so it was like around 230 or something like that. And so they then said, what is the equivalent of that? And because it was just Norco and not something stronger like a fentanyl or whatever, they calculated 15 months. And then I served 11 months of that. And then now, flash forward, I regained my medical license, regained my controlled substance registration. I started Daily Remedy as a platform to advocate against healthcare injustice, and now we talk a lot about health policy, health innovation, and now I'm back practicing. So what's very interesting is that I talk very openly about what happened to me. A lot of physicians don't want to talk about it. And what's really interesting is that as I'm re-establishing my practice and my clinical presence, and I'm meeting old colleagues, they want to connect. They do not want to talk about the case. It's like day and night. So say, hey, how's your practice? How's your family? How's this? Oh, about the DEA situation. Let me tell you what happened so that you can protect yourself if they ever decide to target you. Nothing. Nobody wants to talk about it. Nothing. And what's very interesting is that most physicians would rather just bury their heads than talk about the regulatory targeting by federal and state prosecutors. But until we talk about it, we're not going to destigmatize being targeted clinically, being targeted legally in the clinical sphere. To give you a sense of kind of how pervasive this is in Indiana, if you remember a few months ago, there was an abortion provider who performed an abortion at a 13-year-old rape victim. And the state AG basically just came after her. And it was so bad that she filed, I believe, like a harassment or like a misconduct lawsuit against the state AG. And his name is Todd Rodica. That's kind of the ethos of the state and federal prosecutors is by any means necessary, target these physicians. Because even if the law is not in our favor, we can interpret the law to be in our favor. And you see this paradigm coming around with opioids, with abortion, with vaping. It's not so much about the law itself, it's about how you can interpret the law to moralize a particular stance. All prescription opioids are bad. All prescription opioids are addictive. Therefore, any clinical interpretation that justifies the medical use is incorrect. Abortion takes a life. So any clinical scenario in which an abortion is medically necessary is a crime. So you start to see this paradigm, and now it's extending to IVF, to other clinical conditions. What happens is that there's a fundamental incongruency between healthcare and law. And rather than finding a blend, a compromise, what's happening is that the law is creating these artificial simplicities, these conformities onto the practice of clinical medicine. And as a result, physicians are facing undue pressures. They make clinical decisions with the legal ramifications in mind, as opposed to what's right for the patient clinically. And ultimately, the patient suffers. So that's really my backstory on how I got involved in the social media scene. Before the whole DEA situation, I was very entrepreneurial. I wanted to start establish a medical advantage plan clinics, grow and build something. And what's interesting is that that entrepreneurial sense of resiliency really helped me get through everything and really helped to rebuild my practice. And it's one of those things where I want to talk about it. I want people to know the story, and I want people to know that if something like that happens to them, I'll be there to help you. And what's interesting is I'm working with a law firm called Chapman Law Groups as a physician advocate. So physicians who are similarly targeted as I was, I can give them advice on how to present yourself to the medical licensing board, how to present yourself to the patient population, because the last thing people want to hear is the physician crying victim. Nobody wants to hear stories about physicians who are being victimized. It's just this American culture. Now, whether you want to call it anti-intellectualism, whether you want to call it, classism, there's this prevailing notion that physicians are fair game for being targeted more so than other professions. And what happens then, you have to navigate from that deficit when you're trying to reestablish yourself. So I never go across and say, I'm a victim. Look at my story. Look what happened. Instead, what I try to do is I try to present the whole situation in its full context. I tell people, you can question my clinical decision making. You can question whether I was right to trust a patient, whether I was right to taper the prescription opioids, but you cannot say my actions were criminal. So what I do then is I contextualize it around its appropriate medical context, and I avoid any sort of legal simplicity that'll then distort the argument itself.
Wow, what a background. I have so many questions to ask you, and I just really, even informing the questions, I just really hear, I mean, I hear the pain in your story and the voice of, again, not as a victim, but like as somebody that is clearly frustrated at doing what to me sounds like you thought was just the normal prescribing in a system that really is like out to get you. Again, I wasn't there. I can't vouch for whoever. I don't know you more than just meeting you online, but I hear your pain, and I think it's really incredible that you're using your experience to do good. I guess the first question I have is, it's not every day that we meet a physician that has spent time in prison. How was that experience?
It wasn't bad. I mostly just read a lot of books. I wrote a lot. I wrote Burden of Pain, which details my story and provides medical context around frameworks of medical jurisprudence. Um, I started learning how to write legal documents known as amicus briefs, for which I've written for cases like the Sackler, the Purdue Pharma Chapter 11. I wrote for Walmart v. DOJ when the DOJ targeted Walmart. And of course, I wrote it for Ruan. It was a relatively peaceful coexistence. I didn't really interact with too many people. I kind of just kept to myself. What's interesting, what happens when you go to prison, people judge you right away. So they want to assess, does this individual engage in what's known as hustles? So hustles are ways where you can make some additional money or engage in some sort of scheme, like for example, soliciting cigarettes. So once people found out that I did not engage in any of those types of things, nor I would what's known as like dry snitching, where you basically are a mouthpiece for the guards. Once they realized that I had no intention of communicating with the guards or engaging in anything, I was just there, right? Like nobody had any use for me. The guards didn't have any use for me. The inmates didn't have any use for me. So I was allowed to just read and write. And, I really developed my writing skills there. And I would say before I was a very technical writer, like many physicians. And I think I learned the art of narrative writing by just reading and writing books over and over. I think I got to a point where I was at like a book and a half a day. And it was just wake up in the morning, read, write, and go back to sleep.
Amazing. We have a book section on doctorsonsocialmedia.com in the what's called Beyond Exam Room. I'd like to build your book a page there so
Sure.
that we can display it. And anybody that's listening, I'm going to link it below this episode so they can not only support you, but also read your story.
Yeah.
Um, so you wrote one book in the end?
Yeah. So actually, I wrote it over the course of the last 5 months that I was away. So it's titled Burden of Pain, A Physician's Journey Through the Opiate Epidemic. Um, and it's broken down into two parts. So the first part is my story, and the second part is taking, a very analytical approach to why healthcare and law don't seem to get along. And some of the concepts I talk about are, you know, using frameworks from behavioral economics, using philosophical frameworks of uncertainty. I think the key thing, in the key message really is to understand in healthcare, there is a fundamental uncertainty that dictates how clinical decisions are made and how patient care is managed. If you don't acknowledge that uncertainty, you can manipulate healthcare in any way and create any sort of context that you can justify legal targeting. So I'll give you an example. I talk about vaccines, right? So vaccines is hotly contested. Everybody has an opinion about it, and the more opinions that are out there, the more polarizing it gets. But what people don't realize is that the argument of vaccines is fundamentally incomplete, in that there's what's known as a denominator neglect. In that when you talk about vaccines, it's true vaccines have side effects. And it's true that vaccines benefits increase with the more percent of the population that's used. So to truly understand the value of a vaccine, you have to take both arguments into account and then look at it like a ratio, the individualized risk and then the general benefit. And if you fail to look at it in that way, neither argument is entirely wrong. Vaccines are good, vaccines are bad. They're neither entirely wrong nor are they entirely correct. And what happens is you see many issues, abortion, vaping, IVF, what have you, where you have these fundamentally incomplete, overly simplified arguments that people just keep touting as opposed to looking at the healthcare issue itself in its full complexity. And I argue that we should look at opioids in the same vein, and that we should look at the reduce the benefits and the risk, and then create protocols that help to manage that. Instead, what happens is you have guidelines. So the guideline for this, guideline for that. And essentially what they do is they oversimplify the thinking to just reflexive patterns where A then B, C then D. And that's not good clinical decision making, right? When you look at people like Dr. William Osler or other progenitors of medicine, they always talked about the patient narrative, getting an in-depth analysis, and just diving into the nuances, the granularity of patient care. Well, you can't do that until you appreciate the uncertainty in patient care and looking at that as the guiding lens for patient care. And I think that's where people are really missing. And that's one of the fundamental problems why we keep seeing these whack-a-mole solutions for all these healthcare issues that are not getting better. Like we're cracking down on prescription opioids, yet overdoses are going up. It's not because people are addicted to drugs or because prescription opioids help galvanize that. It's because when you restrict access to care and you stigmatize certain medical conditions, like a substance use dependency, patients will logically then go a route that's away from the healthcare system. Nobody here is an irrational actor. They're all acting according to very rational, very real incentives. And until you start to understand that, you're going to have these whack-a-mole solutions that don't really do much of anything.
It makes me think of the control that we spoke about when you interviewed me for your podcast, when I was talking about, the middlemen that sort of they meddle in decision making. And again, I can see both sides of it. I mean, there should be a good balance to live in where they, sort of dissuade the bad things from happening, but also allow things to happen in order for us to continue to heal. The issue is, again, like you say, when we're trying to be physicians and take the patient at face value for what they're worth and what they're telling us, but instead of treating them, we have to think in the back of our mind about getting in trouble for prescribing, et cetera. And again, I didn't share it with our audience. I shared it on your podcast, but I'll actually share it here again because we were talking about physician reviews, right? Like patient reviews of physicians. And I told you a story, actually, not knowing your past.
Yeah.
I told you a story about a patient that had called and wanted a controlled substance. And basically I said no because I had never met the person. And so obviously I need to see them because, they had gone to the clinic to the doctor before me, but I felt like I needed to at least see them and sort of get to know them and see why am I writing a controlled substance? And when they heard this, they said, well, if you don't write that for me, I'm going to give you a bad review. I'm going to really just decimate you reputation wise. And I was taken aback, like, wow, you're really weaponizing the online world and patient reviews. But really, it kind of weaves into this of like the doctor, being stuck between a rock and a hard place in wanting to help patients in their pain. And that's what really is hard for me as a human, as a formerly
Yeah,
practicing internist. It's very hard. It was always hard for me, right? To know that I want to help the patient, but I also constantly have to think of the repercussions of, for example, like abuse, right? And the potential repercussions of their using too much. How do I, you know, mitigate that? I mean, other
yeah,
than like counseling them and writing it down, the problem is how much is too much? How much is too little? And then it was, okay, so I'm referring them to pain doctors. But then the pain doctors would be like, well, I'm not giving them any pain medications.
yeah,
They need to go back to the internist. So the patient would be the victim here because they would be yo
exactly.
between the internist, the general practitioner, and basically the pain doctor. And again, there's other ways to treat pain, but they don't always work. So again, it's like we're going more and more away from the treatment of that individual because we're so scared of the side effects. And how do we really solve that by still keeping the patient pain free? I don't have a
Exactly.
solution for it, but I'm sad to have heard your story, knowing that you meant to put someone you thought was a patient out of pain. And in your
Mhm.
assessment, it was enough to do the exam that was worth it. Again, for some people, it's why shouldn't we believe a patient when they tell us that they're in pain? Why? And then the other problem I've had, and I've actually written about this, is that when did we become detectives? Like we
Yeah.
went into medicine to heal, to have a beautiful relationship and a partnership with our patient. But this kind of thing almost sets us up for failure because we now need to think of the legalities, and really we're practicing in a CYA kind of way. And for
Yeah.
those that are looking on and don't know what CYA means, it means cover your tushy, but not a nice word for the tushy. What do you
Well,
have to say
so
about
No, I mean, I fully agree with you on this. Let's talk about that example of the patient being shuttled around and different physicians not comfortable prescribing. Uh, Essentially, the fundamental issue here is, and I think part of solving complex healthcare problems is to actually understand the problem itself. Nobody wants to be labeled a high prescriber because that's what the regulatory bodies that be look at. They don't look at the clinical context. They just look, is your number higher than that number? And if your number is higher than that number, I'm coming after you, right? So that's the paradigm that regulators look at, and physicians know that. So what happens is then when they're treating a patient, when if you are a patient to me and you have, let's say, an established history of taking Norco, what have you, and I review your prescription database, I review your urine drug screen, everything checks out. When I make that decision to prescribe, in the back of my mind, I'm thinking, well, it's another count up. So what happens then is you're not looking at what is the clinical context of care. Instead, you're looking at now, how do I look in the eyes of the regulator? How do I look legally? So you're making clinical decisions within a legal context. And for those who are kind of now saying, what are the ramifications of that? Well, a few years ago, the DEA, actually the Health and Human Services, eliminated the X waiver, which then allows prescribers to offer Suboxone and Methadone with fewer restrictions, with the goal being that, well, if we have this big opioid issue, let's increase access to opioid abuse medications. What they found was that even when they eliminated that barrier, physicians were not increasing access to care. Why? Because Suboxone and methadone are controlled substances. So physicians know this, and everybody implicitly knows this, but nobody wants to explicitly acknowledge it. Physicians implicitly know, well, if I have patients that have anxiety, that have chronic pain, that have ADHD, and now I'm treating with substance use dependency, what is that doing? That's increasing my controlled substance count. So instead of looking at this from the framework of a physician saying, I have now the ability to treat an additional patient population that I didn't because I didn't have an X waiver, instead physicians are thinking, wow, I'm going to increase my controlled substance count. That's going to put me right in the throes of the DEA. So what happens now is by oversimplifying how regulators look at prescriptions for substance use dependency and lumping everything together, physicians know I'm going to be targeted. So then they change their decision making accordingly. And that's the fundamental issue. And if you take that framework, that concept on how their implicit thought processes are affected both legally and clinically, you start to see the effects of health policy on health care. You can apply that to abortion. Like many abortion providers in states where it's legal are now saying, I don't know if I want to do this because as we talked about with physician autonomy, many physicians who perform abortions will get left out to dry by their healthcare system if a regulator comes after them. And in fact, there's insurance provisions that'll help protect the health facilities, but won't help protect the physicians. So also now it's becoming a calculation of risk. How much risk do I want to incur? And is there a risk premium to helping the patient that justifies that risk? So when you start to look at healthcare from that framework, you really start to realize why health policy is proven quite feckless in many ways.
Wow, that reminds me actually, it's a great analogy of, and I'm not a surgeon, I was trained as an internist, but that there are some surgeons I read that um, their work and their success is reflected by the mortality of their patients. So what they do is they basically hand select the patients that are going to fare better. And what happens is that they then discriminate against like the patients that maybe are in their advanced age or have more comorbidities. And what you get is this frustrating situation where the surgeon is fantastic, but they say no to patients that could have more risks, and they hand select the patients that are just easier. And it reminds me of that. And
Yeah,
it's a
so
shame.
that's why you have a bimodal distribution of mortality when you look at the average of surgeon per specialty, right? So you have those surgeons who are able to select patients with certain level of ability that other physicians or the surgeons may not. So those quote unquote easy patients, the ones that have really good outcomes, they will go to certain surgeon groups, certain surgical groups, and then other patients who may be deemed not as easy, quote unquote. And again, I use that term relative and not to disparage any patient population. But then another set of surgeons are left with those patients. So you have this bimodal distribution, and that's effectively self-selection. Again, using frameworks of behavioral economics, different incentive structures predisposed onto different physician groups, different patients, and that's why you get the outcomes that you get. Why Medicare Advantage plans are now under quite a bit of scrutiny because they would self-select, right? It wasn't like they were doing anything like overtly malicious. What they were doing is they were self-selecting and then they were stratifying the patients and then they would provide certain services or incorporate certain codes. And what's very interesting is like as recently as 5 years ago, there was a term for that and it's called coding density. So by having a certain number of codes per patient, by increasing them, you can then adjust how those codes react over the course of the patient care. And many savvy Medicare Advantage plans would use that coding density framework to then adjust the reimbursements per patient. Now, is that gaming the system or is that predicting risk? Now, you decide, right? But as long as you're able to look at the argument in the full context, you then have a clear case for how you want to make a decision. Now it's just like Medicare Advantage plans are amazing, next greatest thing ever. Now Medicare Advantage plans are terrible, greedy corporate CEOs, right? Like we oversimplify things instead of looking at it in the context in which it should be seen. And when we do that, we're not really solving anything. We're just flattering our egos.
Yeah, absolutely. And for the sake of time, I'm not going to go into it, but it reminds me of yet another analogy where the healthcare systems are now, employing other members of the healthcare team. And I'm not going to get into the weeds here because I don't want to get into discussion of, um, other providers like NPs and PAs, but systems bring them in to a healthcare visit, for example, and they say, well, we will give them the easier cases and leave the harder cases for the MDs. And it reminds me of a similar thing where you're sort of now selecting the hard cases and putting them on the MDs, and the time limitations are still in place. And so it's almost like a no-win situation for the doctors that are involved.
Yeah, one of the things these MBAs and these business folks will never understand is that you can't apply metrics of success from other industries into healthcare. Efficiency in medicine is not the same thing as efficiency in the retail world or the financial world. And until people realize that you cannot just speed up everything in healthcare, they're going to continue to do put these metrics where patients have to be seen in X minutes. A physician has to see Y number of patients. Now, that's how these administrators think, right? It's like Y productivity over X time, and that's a success metric. But that's not how healthcare works, right? It's not just as simple, we should do this so we can get that outcome. There's so much complexity that goes into the input of patient care that results in the output. You know, think a little deeper. Come up with a more sophisticated system that actually values patient care experiences and gets the outcomes, both clinically and financially, that you want. It can be done. There are practices that do that. Problem is, those are more small practices, right? The independent physician. But when you start to scale healthcare, you incorporate a system. And when you incorporate a system, there's different incentive structures involved. That's why healthcare for the longest time was always this fragmented system where individual physicians would care for individual patients. We somehow lost that and we forgot like the effects of compounding. When you build something up that's a lot greater than it should be, you distort what the original intent was meant to be.
Totally. And the admins that you were referring to earlier, they have no real skin in the game in terms of the immediate healthcare interaction really is still between the patient and the physician. So they can put whatever metrics they want out there, but it really doesn't affect them. It affects the physician who many times has their hands tied behind their backs and don't really speak out. What a perfect title, by the way, for the podcast that we are going to be working on together called Stigmatized.
Yeah.
Jay, honestly did not even know your background story. And I am so much more excited now, having spoken to you and hearing just how eloquent you are and what an amazing, like, personal story that you're willing to share and sort of bring to the table. So, for those people listening, I am really excited about it. And I'm sure that you are too. We've got a series that we're sort of co-producing and creating called Stigmatized. And Jay's going to be the host, and he's going to bring on guests where they talk about different topics that are sort of stigmatized within the healthcare system. Can you tell
Yeah.
us a little bit about that and what you're going to cover?
Yeah, so certainly. Thank you for that. And again, I'm looking forward to working with you as well. I'm a big fan of Somi Docs, and I'm really grateful for the opportunity to work together. What we're going to do is talk about things that most physicians don't want to talk about. We want to bring to light many of the stigmatized issues that are facing physicians. Now, that can be physicians dealing with a malpractice lawsuit that they're scared to talk about because they feel like it's going to hurt their reputation. A physician who is discriminated against in the workplace but doesn't say anything because she wants to keep her job. These silent struggles of physicians should be disclosed and brought out to light because it helps mentally the physicians and it helps to advance our profession as a whole when we can talk about the downsides. For far too long, physicians have this culture of perfectionism that we have to be the best at everything. But in medicine, you have to understand that there are errors by nature. So things are going to happen. Rather than shying away from them, embrace them, talk about them so that we can grow together and collectively develop. And so in the Stigmatized podcast series, I want to talk about these things that most people are uncomfortable talking about. And by bringing it to light, I hope I can share some of the fears and concerns in the medical world and let people know you can talk about it and you can be open and it's okay. And in fact, it's good for you. Mhm.
Amazing. I am
Yeah.
so excited about it. And I think there probably is no better word to describe this podcast than stigmatized. So,
Exactly.
yeah, so stay tuned for that. If you're watching this, you can check it out. It's going to be in the series section of doctorsonsocialmedia.com. Jay's got his own work also that he puts his effort into. But, I want to thank you for coming on here, for being so vulnerable in your sharing your personal story, and for showing us that you are what looks to be an empathetic human being who really wants to, change healthcare for the better.
And well, thank you for that. Appreciate it.
Absolutely.